Thanks very much. We're going to take questions at the end. Professor Kolh is going to follow on now with a review of the evidence for coronary artery bypass grafting. Thanks very much.
Thank you very much, and thank you for the invitation. So I've been asked to address the evidence for coronary artery bypass grafting, which is actually not that many. CABG, I think, remains the benchmark treatment for patients with multivessel coronary artery disease, especially when they have medium or high syntax risk score. The indications are well documented, results relatively satisfying in terms of morbidity, mortality, and ischemic recurrence. But the incidence of risk factors, perioperative comorbidities is increasing, we all know that. And many patients arrive for surgery at an advanced stage with severe left ventricular dysfunction, chronic renal disease, peripheral vascular disease, and chronic pulmonary disease, so with a lot of comorbidities. So to improve the management of these patients, we have tried to some extent to adapt our operative techniques. We have introduced numerous ways to bypass the vessel, trying to decrease the use of the saphenous vein graft, because we know that the long-term patency of this vessel is not as good as double mammary artery or radial artery or even gastroepiploic artery. It is also sometimes interesting to address patients with advanced peripheral arterial disease, so you don't touch the leg. Small incisions have also gained a lot of acceptance. They have the advantage of patient preference. Usually when you tell the patient they have a smaller incision, they are more happy. It probably does decrease the risk of major wound complication, and it does allow for early return to full activity, which can have a positive socio-economic advantage. A more common alternative strategy to smaller incision, if we look at the large database, being European or American, is the use of a full median sternotomy incision, but without the use of coronary artery bypass grafting, beating heart, off-pon, or off-cap. The strategy being used in about 20% of STS reported cases, probably actually slightly lower than that nowadays. So the question from all of that, these new techniques to some extent, and there are also a lot of other variation, is do the changes in operative techniques have a potential impact of a completeness of myocardial revascularization? And the second question in our mind is, what is the impact of complete versus incomplete revascularization for patients having CABG? Does it matter? So what is the definition of complete revascularization also? Well, complete revascularization approach is considered superior to incomplete with better long-term survival, and second, a lower rate of reintervention. But there's consensus among surgeons. We have always heard about the importance of complete revascularization, and sometimes we use that as a potential advantage of CABG over PCI, arose actually following the first long-term observational studies in young patients undergoing saphenous vein grafting. The advantages of complete revasc emerged from long-term follow-up studies showing a direct relationship between the number of treated coronary segments and the reduction in cardiovascular events. But however, it's yet to be established whether this difference is actually due directly to incomplete revascularization surgical strategy, decide not to do it, or whether this approach is merely a marker of more severe coronary disease and possibly also a more rapid progression of the disease. So what is complete myocardial revascularization? I think it's an interesting question that was already addressed by Professor Ham. There is a large variability in the criteria adopted to define the completeness of myocardial revascularization. By interpolation of existing knowledge, a comprehensive definition should probably take into account the size of the vessel. There is a difference between a 2.5 coronary artery and a 1.3, the severity of the lesion, and the viability of the myocardial territory that is vascularized by the lesion. Therefore, an anatomically complete revascularization is usually accomplished when all vessels with clinically significant stenosis that are greater than 1.5 millimeters of diameter and stenosis greater than 50% are treated, irrespective of the underlying myocardial function. That's only looking at the stenosis. Probably more interesting, a functionally complete revascularization instead refers to cases in which only lesions supplying a viable myocardium are treated. Revascularization may therefore be anatomically incomplete if you look at the angio, but still functionally adequate. Such definitions are certainly highly relevant to compare outcomes of different strategies over time. So I think we have very few data, specific data for CABG. As I said, the advantages of complete revascularization do emerge from long-term follow-up studies showing a direct relationship between the number of treated coronary segments and the reduction in cardiovascular events. A large data set derives from the CABRI trial, which was published more than 15 years ago, where an improved long-term event-free survival was documented when all stenosis greater than 50% in diameter were bypassed. Similar results were obtained at the very beginning of PCI procedures. But patients with incomplete revascularization were generally older and with a higher prevalence of severe comorbidities. Thus, the higher perioperative risk of patients not allocated to complete revasc could flow conclusions on the adopted strategy owing to the existence of a systematic bias. Those things are not that clear as we may think at first glance. So the very seminal publication was, I think, a series from Scott, published in GTCVS, showing the patient having isolated bypass grafting of the LAD with the lima to the LAD, so they would not touch the right or the circ. And you can see that this procedure was highly performed in the early 70s, much less in the late 90s, but still in 95. About 20% of patients did not have right or circ lesion treated. And interestingly, this does have an impact of incomplete revascularization, here with patient not having non-NLAD disease, and here patient having any left main trunk disease. The next slide, you can see that in the next 2 or 3 slides, according to the different system. So here, patient had remember, these patients had only lima to the LAD, period. Whether or not they had lesion to the right or the circ, usually the reason why, well, it's too small, I cannot do it. It was not, in most of the circumstances, a preoperative decision. Sometimes it was, but sometimes not. It's like real life. It's interesting. So the higher curve with the filled circle, no non-NLAD disease. So you could say that it was complete revascularization. And in this case, there was circ disease, either the circ itself or lateral branch disease, okay, the open circle, and you see the incidence of survival. Same consideration with RCA. Non-LAD, only LAD disease here, and here patient with high-grade proximal right coronary disease or more distal disease. So according to this study, you can see, well, if I don't do anything on the other lesions beside the LAD, there is an impact on survival. You would say it's logical. Second, the CABRI trial. Analysis of patients with multiple vessel disease, including the chronic occlusion of a major vessel in the CABRI trial, indicates that surgery gives a better outcome in these patients in terms of subsequent mortality and risk of acute MI. A complete revascularization was obtained more frequently in the surgical group than in the PCI group, but we are back in the 90s, so techniques obviously have evolved, principally due to the frequent failure of PCI in the revascularization of the occluded vessel. Now, possible explanation of the clinical benefit of occluded vessel revascularization survival are numerous. They do include improvement in left ventricular function in patients with viable myocardium, prevention or shutdown of ventricular remodeling, decrease in electrical instability and associated risk of fatal arrhythmic events, and increased tolerance of future coronary occlusion should such events occurred. So there are numerous physiopathological explanations that you can use here. The MAS2 trial was published more recently in Circulation in 2010, comparing three types of revascularization, PCI, CABG, or OMT. And it also demonstrated the better long-term prognosis of surgical patients and also confirmed the superiority of CABG over PCI with regard to the need for subsequent mechanical revascularization, which is certainly understandable on the basis of both clinical and anatomic arguments. We know that atherosclerosis is a progressive and diffuse disease, whereas PCI is directed against a target or culprit lesion or lesions. CABG bypasses most epicardial vessels and provide protection, at least in the intermediate term, against disease progression involving future culprits. A functional bypass will continue to protect the native coronary vessel even if it's subject to disease progression or abrupt closure at any proximal site to the graft anastomosis. So that's why in the previous guidelines we came up, William Waynes and I, it was actually published in another article before the guidelines, a comparison of the two techniques in a document that was supposed to be used for the patient, to illustrate to the patient what is the difference between PCI and what is the difference between CABG in how the lesion is managed. And I think it's a clear example where the heart team and the discussion with the patient can be useful. Now, if we look at the syntax trial, it's interesting to see, and Professor Ham has also addressed that briefly, that there are incomplete revascularization within patient lesion subsets. You can see here according to left main only or addition with more than 1, 2, or 3 vessel disease. And usually it's easier to you have higher rate of incomplete revascularization associated with PCI or CABG, but still, it's still quite high in all cases. And if you look at the rates of incomplete revascularization within syntax score tertile, you can see, again, there is a difference. The higher the tertile, the higher the incidence of incomplete revascularization. Now, does it matter? Well, if you look at PCI versus CABG at 3 years, you can see that that's published about a year and a half by the people from the syntax group. And you look at MACE, death, stroke, and MI, all-cause death, MI, and repeat revascularization. And interestingly, all this curve, this is significant for MACE, for PCI, not for CABG. There is no difference between incomplete and complete revascularization with CABG, but there is for PCI. Regarding death, stroke, or MI, so hard endpoint, removing repeat revascularization is just significant or almost for PCI, not for CABG. And no difference in death or MI. And for repeat revascularization, highly significant in the group having PCI and not in the group having CABG. Now, in the last part of my talk, what I would also like to emphasize is the importance of the clinical features of the patient. Probably supplying at least one graft to each of the 3 major myocardial territories is probably of far greater prognostic significance. It probably doesn't matter that much if we leave a small diagonal or a third branch of the third unbypassed. Clinical features should influence the choice of a complete or incomplete strategy of revascularization in selected patient categories. Certainly diabetics benefits more from CR, better perform with CABG usually. In patients with left ventricular dysfunction, revascularization of all viable segments should be accomplished in order to maximize benefit. These patients, they are quite important to receive full revascularization. In the elderly or in patients with severe comorbidities, effort should be taken to reduce acute adverse events, and very often the additional perioperative risk entitled by attempts of complete revascularization appears to be unwarranted. So in this case, probably go for incomplete revascularization as needed. So what do we say in the guidelines? Well, what we wanted to emphasize is the importance of ischemia. And here we show the previous publication from Hashamovich, published over 10 years ago in Circulation. There is an update, I think, from last year with higher number of patients. You can see that the curve comparing medical treatment and revascularization cross at a level of ischemic myocardium of about 10%, 10-12%. Below that, medical revascularization does better. Above that, there is no question that, medical treatment below 10% and mechanical revascularization with PCI or CABG do better above 10-12%. So in the guidelines, we emphasize that. What we also took into account was the FAME trial, in which patients with stenosis greater or equal to 50% in at least 2 of the 3 major epicardial vessels were amenable for stenting, and the patients were randomized. Now, it's not a CABG trial, but I think to some extent we can take what is shown in FAME and FAME2 and in a discussion think whether it does apply to CABG patient. So it was randomized between either angiography-guided PCI or FFR-guided PCI and measure FFR in all indicated stenosis, and it will be discussed by Professor Ham in the next session. So angiographically guided PCI, all stenosis were stented, indicated, obviously, you need a significant stenosis. You're not going to put a stent in a coronary artery without a stenosis. And on the right, only the stenosis with an FFR equal or below 0.8 were treated, 1 year follow-up. Let's go through the procedural results. What's interesting is the event-free survival. And you have an absolute difference in MACE-free survival at 1 year, 360 days, in favor of a FFR-guided treatment for PCI. But why not for CABG? I am asking you the question. I don't see why there would have been a difference if it was CABG. Well, maybe it's a different technique, but I don't think so. So what we did in the guidelines is to strongly emphasize the importance of ischemia. We have here the indications for revascularization in stable angina or silent ischemia, according to the anatomical pattern of the disease, left main, proximal LAD, 2 or 3 vessel disease, and so forth. And you can see the asterisk. And this asterisk does refer to the extent of ischemia. It's important that the patient has documented ischemia before the cath or fractional flow reserved measured during the cath procedures should be below 80 for angiographic diameter stenosis between 50 and 90%. And then you have revascularization for symptoms where the demonstration of ischemia is not as important. You can assume that if the patient has symptoms, there is ischemia. So after so these guidelines were released in 2010. As I said, we are doing a second set that will be released later this year. We'll see if we change some things. We cannot discuss that before they are published. But after we did the 2010 guidelines came the FAME2 trial that was presented at the ESC in 2012 and published simultaneously online in the New England Journal of Medicine. So what they did in the FAME2 trial is to have stable patients scheduled for 1, 2, or 3 vessel PCI with blood-eluting stent. And all patients here at FFR. That's a different strategy as compared to FAME1. So either patient at least, so they randomized after the cath. They knew what FFR was. So at least one stenosis with an FFR below 0.80. So according to the guidelines, that the ischemic lesion or a lesion that does trigger ischemia. And these patients were randomized between optimal medical treatment or optimal medical treatment with PCI. And when all lesions were above 0.80, then it was a registry with only medical treatment. Okay? Follow-up 1, 6 months, and up to 5 years. This is the randomized trial. This is the registry. 73%, 27%. And guess what? On recommendation of the Independent Data and Safety Monitoring Board, recruitment was halted after, early January 2012 after inclusion of 1,220 patients, about half of the initially planned number of patients because of safety problem. And the reason being, what was the primary outcome? Well, here you have the registry. So actually, it's very safe to follow patient without an FFR, a significant lesion, on optimal medical treatment, okay? Even if you think it's a high lesion on angio. While you have patient on medical treatment and randomized, you have a 15% cumulative incidence at 1 year. And when you have PCI plus MT, so randomization with PCI, you are at the registry level. So this is obviously highly significant. It means that when a patient has ischemia demonstrated by FFR, treatment by PCI in this case is recommended, but I think this can be used for the discussion for CABG. Now, there is no difference in death. There is no difference in MI. The major difference is in urgent revascularization. So I think these cases, mostly, again, I would like to emphasize the importance of the discussion within the heart team. Also, when we consider the possibility of treating or not treating a particular lesion that may be borderline. We are not talking here about a big proximal LAD or a left main lesion. So in conclusion, regardless of the mode of intervention, CABG or angioplasty, I think the ultimate value of completeness of revascularization is difficult to elucidate. In patients with multivessel coronary artery disease, including the chronic occlusion of a major epicardiac vessel, CABG can offer a higher probability of a full revascularization inherent to the technique and a higher probability of remaining alive and free of acute MI in the long term. The extent of myocardial revascularization accomplished by either technique is likely a major determinant of survival among patients with ischemic heart disease. On the basis of available evidence, revascularization should be at least functionally complete. Functionally, I think at this stage, that's the most important key message. Among stable, non-diabetic patients with multivessel coronary disease and good left V function, standard patient. Clinical features should also influence the choice of a complete or incomplete strategy in selected patient categories. And as I said, diabetic patients benefit from a more complete revascularization, and CABG so far is probably better. In patients with left ventricular dysfunction, the revascularization of all viable segments should be accomplished. And in the elderly or in patients with severe comorbidities, we should probably tune down the objective of complete revascularization. Thank you for your attention.